So historically, for the treatment of bladder cancer, the use of adjuvant chemotherapy in patients who have undergone definitive cystectomy has been somewhat controversial because the studies that had been designed to demonstrate a benefit with cytotoxic chemotherapy had variable designs, some design flaws, closed early due to poor accrual, and ultimately, while there is data suggesting a benefit with adjuvant chemotherapy, it's always been somewhat controversial. With a new class of drugs, immune checkpoint blockade showing activity in metastatic disease, clearly a logical proposition was to move these drugs earlier into the adjuvant setting. There have been a number of clinical trials, large randomized trials, really asking a similar question with different PD-1 or PD-L1 inhibitors, and that is, should we use these treatments in the adjuvant setting after cystectomy in patients who've already had neoadjuvant chemotherapy and have residual disease at the time of surgery? Or should we be using them in patients who couldn't receive neoadjuvant cisplatin-based chemotherapy due to not being eligible for cisplatin therapy and use these in the adjuvant setting compared to no treatment in the adjuvant setting at all? So two somewhat distinct patient populations receiving these drugs in the adjuvant setting compared to observation or placebo. The trials were designed a little bit differently. We know from the IMvigor10 study, which was reported last year, that there wasn't a benefit to the use of atezolizumab in this patient population, regardless of tumor expression of PD-L1. Now we have a press release with CheckMate-274 using nivolumab in a similarly designed study that has indicated a significant improvement in disease-free survival in both the all-comer population and the population of patients restricted to tumors with high level of PD-L1 expression. We know that these drugs are not exactly the same. We know that the trials, while similar, are not exactly the same. We know that the biomarkers, while similar, are not exactly the same. So there are differences. We haven't seen the full data from this study yet. And once we see that, we'll need to determine if the effect size is such that this changes practice. And if so, how does this differ from the results of the study that were already released? And can we explain that?